Okay, we're recording.
Okay. All right, so, as I mentioned, this is a modification of a talk given previously. So some of you may find some of the slides familiar, but there's new data, and I think you'll appreciate there's some local Winnipeg data that I will present to you so you get a sense of how big a problem this really is. We're going to talk about the fetal effects of drug exposure, because that's often a big question. We're going to look at withdrawal states and what that looks like exactly. I'm also going to share with you something that's a local quality improvement project. And some of you may be aware that we did this, but I will go through what exactly we did and what kind of effect it had. And then we're going to talk about when to treat and how to wean. So, in terms of the size of the problem, I don't think it'll shock anyone in here to hear that, drug withdrawal in the newborn is not an infrequent event in Manitoba. If you look at this is a repeated national survey on drug use and health. This is out of the U.S., but they found about 6% of women have used illicit drugs in pregnancy. About 1 in 10 women consume alcohol, and one in roughly 6 smoke cigarettes. So when you're looking at the U.S. data and comparing that to Canadian data, you can pretty much divide everything by 10, because that's roughly the ratio that we see in Canada. So put it into Canadian context, about 38,000 or 40,000 people or babies are exposed every year to illicit substances, and about 55,000 would be exposed to alcohol, and about 100,000 are exposed to tobacco in utero. So it's no surprise then that you will see this, and you will get called to go and pick up babies who they suspect are withdrawing. This may also not shock you, but this is out of the U.S. We've all heard, or many of you have heard, I hope, of the opioid epidemic. And the opioid epidemic is referring to the trend over time, and you can see going back to 1999, the red line is opioids, the blue line is cocaine, and the green is heroin. And what you can see is that the use of cocaine tended to peak in about 2006 and has been coming down, whereas the use of opioids has been going up. Now, why is that? That is because, and this is of course showing deaths related to opioids. So why is the death rate going up? It's because of a trend to prescribing opioids for control of pain and suffering and discomfort in pregnancy in the U.S. It became very pronounced in the southern parts of the U.S., where I don't know exactly what the ratio was, like how much, like 1 in 5, 1 in 10, but it was very common for doctors to be prescribing opioids. And so with that, there's been issues with opioid-related deaths. When you look at Ontario, so this is getting closer to home, this is a very frightening curve, I think, because when you see it, you see going back to 2002, this is how many opioid or alcohol, that's both, with opioid in blue, opioid and alcohol-related deaths, and you had about 200 back in 2002, and now you've had over triple the number by 2014, and that number, I don't have more recent data, but I suspect it's gone kind of like that. So this is a real problem, and I would say Manitoba, if I had the same data, would probably not look too dissimilar as far as the trend line. The numbers would be different, but the trend line would be similar. Now looking at Winnipeg, and this is now 7-year-old data, so a little over 1 in 10 women consume alcohol in pregnancy. So we're above the Canadian average. But when you look at the city of Winnipeg, and this will not surprise you, the percentage of women using alcohol in pregnancy ranges from a low of 3 to a high of 1 in 4. About 1 in 5 women smoke cigarettes during pregnancy, compared to the previous slide where I believe I said about 1 in 10. And that is about almost double the Canadian national average. And in some areas of Winnipeg, and I don't have the hard data to link it with the alcohol, but I would venture a guess that the places where there's about 25% alcohol use, that's the same places with the 43% smoking. So that was a problem. Again, this is just speculation. If you were to go further north, if you were to go into many of our reserves in the north, these numbers would be several fold higher. What are people using? Now, again, this is now 7 years old, but alcohol, marijuana was common, cocaine, ecstasy, opiates in the youth. If, again, this is 7 years old, I suspect if we were to look at this today, you would see... What's that?
Meth would be number one.
Meth would be up there, heroin would likely be up there, other opioids would be up there. It'll be interesting to see after October 17th what happens with marijuana and whether we'll start to see a real rise in that. My own, this is just speculation, is we're going to see a spike, you know, as a bunch of people decide to try it, who maybe had for one reason or another not. But I'm hoping that we then see that come down. And we won't get into a conversation right now about the benefits of marijuana. I know that there are clearly benefits, medical benefits and so forth, but when it comes to the fetus, I would hope that we're not having a huge spike in women who are pregnant trying this medication. So why is the fetus at risk? And this is a truism about all drugs that affect the fetal brain are lipophilic. So that means they dissolve well in fat. So this is why a preterm infant who has, like a 28-weeker who's got only about 1% body fat, isn't likely to suffer severe withdrawal because the drug hasn't gone into the brain. There's nowhere for it to go. There's so little fat. We know that the fetus is also at risk because they're an innocent bystander. They have immature liver enzymes. They're not able to degrade the drug as it's passed to them. And we also know that the fetus has a very, very low renal clearance. So, excuse me, when you expose these kids, there's really nowhere for the drug to go, so it hangs around for a long time.
What was MW?
Molecular weight?
Molecular weight.
Okay.
So when you think about pregnancy, it's very convenient to nature has really divided it nicely. The first 20 weeks is all about cellular division, and the last 20 weeks is all about cellular growth. So if you have a lot of exposure to alcohol and it leads to death of dividing cells, you can get a growth-restricted infant, and you can get abnormal brain development. In the last 20 weeks, as your brain is growing, and that's when it's really, you know, laying down all the tracks, if you have a lot of alcohol around, that can certainly disrupt that and lead to fetal alcohol syndrome. So I mentioned you can lose total body cells that are dividing, which would lead to growth impairment, so you could have a growth-restricted infant. Physical abnormalities, you know, we haven't discussed per se, but what are some of the things that you might see with fetal alcohol syndrome?
Widespread, everything that
Yeah.
looks widespread eyes, missing, breach of the nose.
Yeah, flat philtrum, thin
Low
border.
What's that?
Low set ears.
Yeah.
Not,
Yes.
yeah, not so much, but you can get microcephaly. Yeah, so that's thin lips is the thin vermilion border, which is the top of your lip would look very thin. So that's preterm birth, you know, maybe a medication effect. It may be related to polydrug use or mothers who have not been taking good care of themselves, or they're in abusive relationships. There's many reasons for that. Mental retardation, and certainly neurobehavioral. I mean, as a transport team member, the neurobehavioral stuff isn't anything that you're going to have to deal with on transport, of course, because this comes out years later. But that's just something to be aware of, that not all, so there are kids who have fetal alcohol syndrome, and then there's fetal alcohol effect. So you can have children who look otherwise well, but then they get into school and they have lots of problems with hyperactivity, violent behavior, lack of concentration, poor school performance. Yet they're not dysmorphic in any way. They probably have more of an effect, a neurobehavioral effect. Long-term effects, now the problem is that there really are many confounders. So, you know, if a mom's been using alcohol and marijuana and an opioid, you know, and she's been abusing benzodiazepines as well, which one is really the culprit? If you look at sniffing, which is not as big a problem now, but sorry, I shouldn't say that. It's probably still a big problem, but sniffing solvents was a big problem about 20 years ago on the reserves, and it was very well publicized. There was a big debate about whether there was a fetal solvent sniffing syndrome, and it's subsequently been concluded that it's probably really the alcohol that led to the similar features to fetal alcohol syndrome, and it's not a distinct syndrome. Then you get to the nature versus nurture. So if you've been exposed to a drug, we know that chronic exposure can lead to abnormal outcomes. But if you're raised by people that never went to school, that don't read to you at night, that do a lot, that basically leave you in the corner to develop on your own, how much of the mental retardation or poor school for performance is related to the drug? And that has to do with degree of parental involvement and apprehension, foster care. But there is some evidence, and I'll get to it in a minute, that maybe it can be overcome, that nature versus nurture debate. But for reasons that I'm not really clear about, there is an increased rate of strabismus and problems with visual acuity in babies who have been exposed to a significant amount of drugs or gone through withdrawal. There's some motor deficits, there's cognitive impact, we knew. So then the nature versus nurture, we can thank the Israelis because they did a very interesting study where they took 160 babies, all born to mothers who used heroin, and when they looked at the socioeconomic status of the families that adopted these kids out, essentially the kids that got adopted out to high socioeconomic status families did really well, and the kids who got into low didn't do so well. And there's a multitude of reasons for that. Is it the loving, nurturing environment that facilitates growth or better development? Did these families invest more time in the kids? Were they reading to them more? Were they, helping them do their homework? All those sorts of things. Or is it another thing? Is it possibly that affluent families or more affluent families were able to pay for private PT, OT, tutors, all of that stuff? But so the point is you can overcome some of the deficits. So then shifting a little bit to screening. So how do we pick these kids up? So this is more getting now to something you might find in the charts. So you can look at a selected approach and a universal approach. So the selected approach is, for example, if I have Jamie in my practice as a prospective mother, and she comes to me 20 weeks pregnant, and I say, I've talked to her, she's got a little bit of higher risk stuff going on, don't like the crowd she's moving in, and so because of that I'm going to screen her baby. I'm not going to screen someone else's baby, but I'm going to screen her baby. So the problem with that is it's a bias, right? What you're doing is you're attributing somebody's lifestyle choices to the risk that they're going to be using illicit substances. You wind up missing infants because you know who you miss. Who do you miss, Jamie?
A middle class white woman.
That's right.
That probably takes a lot of benzos.
Or the high.
Or the high, yeah.
You're going to miss,
Yeah.
I mean, I like to call it the tuxedo syndrome. You're
Yeah.
going to miss the tuxedo mother, or River Heights, or pick whatever high income area in the city you want. You're going to miss that mother who goes to all of her appointments, but happens to have an addiction to cocaine, or happens to have, or like benzos, or heroin, or because they can afford it, right? So you're going to miss those. The problem with universal screening is, sure, you're going to pick up lots of cases, but there's a high false positive rate. So the example to that would be, Barb, let's say you suffer from chronic back pain. You were on codeine daily, right? Let's say you forgot to disclose that to me, right? Because you've had it for years.
Just done it in, yeah, okay.
You've had it for years, and when I talked about drugs, you didn't even think of it because it's for your back pain, right? So then, unbeknownst to you, we do the screen on your baby, and lo and behold, it comes back positive for opioids, which is exactly what it would come back as. And what would happen is I would approach you and say, is there something you didn't disclose? And you'd say, no, I was honest with you. and say, well, we have to have a talk because there's opioids in the baby. You go, oh, right, I do take a daily codeine, right? Because you don't even register so you can get high false positive rates. And there's also sometimes there's issues with cross-reactivity where you'll get weak positives for things related to medications that are similar. So I'm not sure what exactly is best. We here do not do, we don't do routine urine screening, but we certainly do ask mothers.
Can I just ask, so a high false positive, I mean, the mom is obviously still taking something.
Right.
So even if it's not an illegal substance,
still
it's
picking
still an
Right.
opiate.
Right, the one that you're worried about though are the false like the true false positives, where it's a cross-reactive substance,
Oh,
and then
okay.
you've labeled them.
Were you
As-
eating a lot of poppy seed muffins?
Right.
Oh.
Yeah,
Oh,
like you label them as something that they're not.
Poppy
Okay.
seed eater.
I just
Poppy
had
seed
it for
muffin
breakfast.
eater.
Yeah, exactly. Yeah,
Sandy, we found poppy seed in here.
yeah.
Then I'll leave it to it.
Okay.
Then there's, and the other thing, of course, that you don't get with the screen is quantity, right? So if a mother, let's say, and by the way, I love this topic, and I'll tell you why. It's because I can say the mother throughout the entire talk
Yeah.
and offend no one, and say, well, what about the dad? Well, no, the father's not delivering the baby. So I can safely, use the term mother. Now, marijuana can last for a long time in your bloodstream. And so a mother who, let's say, smokes a couple of times a week, will test positive. It's the same as a mother who's smoking daily. It's not a quantitative assessment, it's a qualitative assessment. So it just, you have to have further questions. So identification after delivery. Urine testing that's what we use if we ever do use it. The only problem with that is if a mother hasn't used in the last 48 hours, in particular drugs with a very fast metabolism, you won't find them. Meconium works. In the US, a lot of places use this. It really will detect everything that the baby's been exposed to in the third trimester, so it's very sensitive, it's expensive, and the other problem is it takes several days to get the results. So it's not very helpful if you find, a patient who has no prenatal care, you do the stool testing, 3 days later, mother's, been discharged after 1 day, and you find out there was heroin. So now the mother's gone back up north, or she's gone into the community, and you have to track her down. So we don't do that. What about clinical findings? So the principles, and this is why what I really like about this topic is you don't have to when you're in university, you memorize a lot, right? And so okay, what is the withdrawal syndrome for this and this and this, and you would just read the book and you would memorize it. If you can picture, even from a movie, what a person who's taken too much heroin looks like, or a person who's taken cocaine looks like, the withdrawal effect is the exact opposite. So, Albert, if you had taken cocaine, you were really bouncing around, you couldn't sit still, you're jittery, what might you look like when you're withdrawing?
This.
Exactly. He might look.
Sorry about Albert.
That was beautiful. He might look like he's just eaten lunch. He's postprandial. He's fatigued. He's not moving. His eyes are barely open. He can't stay awake. Right. Now, you can contrast that with Barb right now, who can't sit still as she's laughing, right? So she could be withdrawing from a benzo, right? All right. Now, onset of symptoms can be anywhere from 24 to 72 hours, and sometimes longer if you have something like methadone, which has a half-life that's very long. The important thing is, almost all people or babies withdrawing from a drug, truly withdrawing, have some symptoms. And that's how we actually track these kids. It can last up to 8 weeks. You can have irritability for 3 to 4 months. So the challenge with the irritability is, and again, you get back to that socioeconomic situation. There is a clustering of a lot of illicit substances amongst people with low socioeconomic status, who have very little patience, who have a lot of trauma and stress in their own life, and if you send them home with a really irritable baby, you could wind up with a shaken baby. So these families need a lot of coaching and a lot of support on how to deal with some of this irritability. Because if you've wandered through the IMCN at any time, you can pick out that shrill cry of the kid that's withdrawing, and imagine having that at home all day long. So neonatal abstinence syndrome really clusters into these 5 categories. So I would say neurologic signs are the ones that we're probably most accustomed to. That's the jittery baby. That's the thing that we mostly think about. I talked about the high-pitched shrill cry, the child that doesn't sleep, seizures, clearly that's an issue. Autonomic system, there's lots of sneezing and skin mottling, gastrointestinal. Some of these kids just won't feed. I find more often it's the exact opposite, that these kids are ravenous. And they get the munchies, and they just eat and they eat and they eat. And sometimes you'll see these kids have, and they have these TFIs of like 250. And now having said that, this is still true, because that's when we've treated them. Then they get their appetite. But prior to getting their appetite, if they're withdrawing, they tend to have the opposite effect, which is not feeding. And they may be tachypnic, they may have worse apnea if they're slightly preterm. And they scratch. So sometimes you'll see we have the little mitts on them or the coverings so that they don't
And
do
their
that.
bones, because they just get such bad diarrhea, they have like.
Diarrhea is bad. Yeah, sometimes we put them on lactose free. I like to include this slide just because I was fascinated by this. Like, it would be hard now to get this into the literature as evidence, but this is a letter to the Lancet in 1989. And the long and the short of it is, this was a mother that was on methadone. The baby came out and was flat, or needed support. They gave the baby naloxone and the child had a seizure. And after this report, it made it into the literature that you need to avoid giving naloxone when you have a mother that's been chronically using. So, in case you're ever wondering, if somebody says to you, well, how strong is the evidence for this? Based on this, there was never a trial. This is the sum total of all the evidence in the literature about naloxone and seizures. It's just based on this one report. But you can imagine no ethics board is ever going to let us do a randomized trial when the outcome is seizures. To say, does it really cause seizures? So that's the question: is, was this baby, baby asphyxiated? Was this baby going to have a seizure regardless? Or was this just a coincidence? We'll never know. So that's why you don't give naloxone. Seizures, however, are actually quite rare. Now, I haven't repeated this search recently, but I came up with 10 hits that were all case reports of neonates having seizures during the withdrawal period. I have seen one baby actually here that I really believe did have a withdrawal seizure, but aside from that, I've not seen any of them. We do tend to treat with phenobarbital, and I know this is something I've had to work on with our transport team because it's confusing. If you're a pediatric patient, they tend to give you diazepam or lorazepam. In the newborn period, we tend to use phenobarbital, but phenobarb works. Abstinence scoring, you probably know, was developed by Finnegan. It's interesting, what comes around goes around. It was designed for narcotic abuse back in the 80s when that was the big drug being used, and so it was not designed for the stimulants. Interestingly, a lot of places apply this as if it was designed for the stimulants, and you should not, because remember, the signs of withdrawal are the opposite of the signs of the drug effect. So higher scores do equal worse withdrawal, but when you look at the scores, all of these things, sleeping, excessive crying, tremors, and whatnot, are all based on observations in babies exposed to opioids. So the score was validated for patients who were exposed to opioids, not validated for these other things. So it's difficult then to apply this, and you'll see sometimes people will say we should, mom was using alcohol and marijuana, we should do NAS scoring. When you see that, that's not really appropriate because you don't know how to interpret the results. One of the things that I have found about this scoring system is it's a very biased system. It would be very hard, and I say this as a physician who doesn't do the scores, but when you look at some of these scores, I've always thought to myself, if I'm a nurse and I'm at the bedside and I get handover and I'm told this patient we're monitoring for neonatal abstinence, mom was on this drug or that drug. Some of these things are objective, Some of these things are not so objective, like excessive cry, increased muscle tone, convulsions I would hope are reasonably objective. But coming up with how bad the tremors are, if it's an overactive moro, if I'm worried that I'm going to undercall something, I'll probably score higher. And so you may wind up treating more. Poor feeding. I also find, what do we call a baby who's feeding every hour and a half?
Annoying.
Annoying. A snacker.
Yeah.
Cluster feeding.
Cluster feeding.
Yeah.
Well, if your mom took methadone, you get a score of 2. That's a problem, right? So how do you know that that's not just a baby that maybe just is like that? So it's the best score we have, but I'm just saying there's a little bit of subjectiveness to it.
So, okay.
Yeah.
So what do you say to a referring set says we got a baby in cocaine and scoring 12 on the Finnegan?
So if they're scoring, yeah, I guess in that way, if they're scoring really high, I would be worried. It's when they
But-
score low. It's when they score low that I'd be more worried that.
But you say it's not made for cocaine, so.
No, but I mean, but those symptoms. I mean, if you're having all of those symptoms,
Yeah.
there's something wrong. And then the other thing.
Well, okay, so I guess
Yeah.
my question, I did that question wrong, is that we're using the Finnegan score to score a baby that mom was on cocaine.
Right.
So,
It's probably the best you can do. The other thing, the other reason, and I'll take it back, I guess. The other reason to use the Finnegan is because when I was going through medical school, what I was told about women who abuse drugs was that always remember they lie.
mhm.
So they may have disclosed that they're using cocaine, but they might hide for whatever reason that they also use IV heroin.
Mm.
You know, so you're probably better off erring on the side of caution and just scoring them.
And then,
But when the scores are low, that's where I wonder, you know, if they have a jittery child, let's say, that could be from cocaine. That's more toxicity,
like,
right? But there is a fly in the ointment here, and the
Okay.
fly in the ointment with all of this scoring stuff is, this is the first 72 hours of life of babies. This was a study looking at normal, healthy babies that went to a normal nursery, and where they actually had nurses blindly score them. So they didn't tell them. Well, actually, what they did was they said, I think they said some of these babies were exposed to opioids, some of them were not. And then what they did was they said to the nurses, please score these babies and tell us what their scores are for the first 6 days. The truth was none of them were exposed. And so they had them score them. And so
really?
the 10th percentile was a score of 1, which went to 0 at day 6. The 25th percentile was a score of 2, which went up to 3. But when you look at the 50, so that's the 50th percentile, sorry. When you go to the 95th percentile, which is this line, there were normal newborns that had scores of 6, right? So the next time you're scoring a baby and you get a score of 5, 4, 6, that could very well be normal. The other thing is, much like many things in our lives, there's diurnal variations. So this is over the course of 24 hours, 24 hours, 24 hours. You can see a pattern. Midday it's higher than it is at the end of the day. Okay? Every day. So that's why, and you know, this I think is good for nurses to know too, because one of the things that you sometimes hear is somebody will say, well, do you think it was the nurse, right? Because the scores are low overnight, and then in the middle of the day suddenly they jump and then they come down. It might not be the nurse. It might simply be that the baby does have these diurnal variations. So that's just something to be aware of, depending on when your transport is called to go. And actually, this is an important one, right? Because this may explain why, because I'm sure this has happened to you. You get a call to go to Dauphin. Mom's been taking methadone or morphine, and you're told the scores are off the chart. You get there, you have a look at the baby, you go, you know, it doesn't look so high. Were they wrong, or is it just that you've actually hit the nadir? Okay, on to drugs. Sorry, how are we doing for time? Oh, 27 minutes, okay. I think, I might get through this. All right, so drugs. Opioids. So the first substances with identical withdrawal syndrome, and we talked about that in 86. You will see some form of withdrawal in over 50% of pregnancies. For the most of the opioids, you're going to see day 3 to 4 is where it peaks, and that's why we try to not discharge these kids right away, because that's often when it peaks. Now for methadone, we're talking at least 5 days. One of the drugs that you're starting to see a lot more of is buprenorphine, which is used in Ontario patients, and I'm told may start to get used here more frequently, like may get swapped out with methadone. And the incidence of withdrawal that requires hospitalization is about 25% with buprenorphine instead of 50% with methadone. So, excuse me, I'm certainly in favor of seeing that switch over. For non-opiate drugs, as I mentioned before, there's few true withdrawal syndromes. You may be looking more at toxicity than you are at withdrawal. Things like cocaine or methamphetamine, which cause vasoconstriction, can lead to growth problems due to placental vasoconstriction. The placenta may essentially break off from the uterus from the vasoconstriction, leading to an abruptio placentae. And you can also see cerebral malformations, so holes in the brain related to vasoconstriction. The other problem with all of these, much like any studies looking at withdrawal, is polydrug use. So looking at treatment, the first thing, there's a picture there of a baby on a mom's chest, because that is probably the best thing we can do. When we talk about treatment, our brains are programmed, maybe yours aren't, mine has always been, programmed to immediately jump to drugs. How, treat the problem with which medication do we need to use? But the reality is, a lot of these babies can be successfully treated simply with non-pharmacologic approaches. So these babies, I would say, if you've not used drugs but you have consumed alcohol before, and you've consumed, and I'm not asking for a show of hands, but if you've ever consumed more alcohol than you wish you had, and in the morning you wake up with the hangover. If you're like other people who have woken up with this, the last thing you want is your cousin, brother, or sibling playing the drum set in the basement when you are feeling that way. You want a quiet space. So we do the same thing for these kids. Calm, quiet, put them in an isolette, put them in a corner where they don't have neighbors on both sides. Gentle handling. Sorry. You also want positive stimuli. The positive stimuli would be skin to skin, as the picture shows, frequent feeding, vertical rocking, C position swaddling. These things have been shown to seemingly make a difference. And we often give them hypercaloric feeds. Their metabolic rates are high. So one of them, as a baby, there's not much you do so there's not much that you can do to manage, to try to avoid things that will irritate them, but hunger is something that will irritate children, right? So feed them frequently. And a few of them actually need IV. A lot of these babies you can manage with oral. So non-narcotics, example would be diazepam or lorazepam, if moms are addicted to that. You can often just use phenobarbital for that. So, as I said here, do as I say, not as I do, and that has to do with the quality improvement project we did. So the quality improvement project was this. Do people even know about this? The opioid quality improvement project we did?
That's when you have the moms stay for a week.
Right, all right, so we have at least one person who knows. So from 2009 to 2012, this was the state back then that all babies, if your mom was exposed to methadone, we really believed that almost every one of them would need treatment. So all these babies were admitted to IMCM, and we were inundated with these babies. 92% of the babies in that initial 3-year period needed treatment, and they stayed for 21 days. From 2014 to September 2015, we did an intervention where we were able to obtain an agreement with the postpartum ward that they would keep these women for up to 7 days, and if they needed to stay beyond 7 days, then they came down. So previously we had 92% getting medical treatment. Now we were down to 41%. We also shortened the length of stay by 4 days. So in July of 2016, we were able to continue the stay for up to 7 days. And what we also did was we did an audit looking to see how compliant are we with what we say we are doing. That's why I said do as I say, not as I do. It turned out we weren't very good, yes?
sorry, 41% of them went home, so I mean 60% were treated, yeah?
41% were discharged home without an IMCN visit, right, so 59%, yeah, sorry, you're correct, 59% were treated. Now, not necessarily all treated though. 'Cause some of them may have come down because they reached their 7 days and weren't quite ready to go home, and so they just needed a bed.
Okay.
But I would say probably about half needed treatment. But back in 2009 to 2012, we had a guideline, but what we discovered was when you looked back through the chart with the retrospective review, you discovered 25% of infants were started on treatment without actually meeting our own written criteria for treatment. 57% were appropriately started, and 18% were started after they'd met criteria. So one way of looking at that, and I don't have the number there, but you can add it together, 43% of the babies that we were treating were treated at the wrong time, either too early or too late. And we know that 77% of the time, what we said should be done for these babies was not followed. So roughly half the time, we were either too early or too late, and 3/4 of the time, when we did do treatment, we used the wrong drugs or the wrong doses. So that's not very good. So we got on top of things. And what we found was, and this is, I like this graph, I made it myself, but I like it because what it shows you is that overall, if you'll believe me, there's a general trend upwards for more admissions. But the red bar on the bottom is the NICU, Notre Dame, and the orange is all locations, which would be postpartum. So you can see that although the overall number has gone up, and this reflects exactly what I presented at the beginning with the opioid epidemic, the number's gone up, but the fraction or proportion of babies that are managed on the postpartum ward has gone up. So I take that as a good thing. So this is almost too small to see, but this is our NAS escalation guideline. And do you all have copies of it? So we should get you copies of this, because this is really what you should be doing. I mean, most of the time, I would imagine if you're not going to be the one to start the medication, but the first medication that we would start would be typically morphine. And you can see that you would initially load, and this is the big thing. You want to load, we start with 0.1 per kilo, and then we start a maintenance of 0.05 per kilo with the scores. If you have 3 scores of 8 or above, or 2 scores of 12 or above in a row, or an average that equals either 8 or 12, you institute treatment. And these are the paths you use. Our transport team won't need to use clonidine, and we might use phenobarbital. If you called me and you said, Michael, I'm picking up a baby here who's been exposed to diazepam and alcohol, and mom was taking cocaine sometimes, and they're bouncing off the wall. I've scored them, their score is 12. I would probably say to you, give them phenobarbital. Okay. Whoops. To wean, and this you won't have, I'm just showing you this so that you know that this is what we implemented. By no means do I expect anyone to memorize this, but we have a standard weaning protocol. For clonidine, we have a weaning protocol, and phenobarbital, we have a weaning protocol. And what we've done is we really had a blitz to make sure everybody knew this. We handed out the cards to all of our staff so that when you're on call, you would follow things appropriately. And the reason we did that was because for those of you who, I always like to tell stories and liken it to something else. For those of you who suffer from headaches, if you do, you would know the best thing if you've got a bad headache, the moment you feel it coming on, first twinge of pain, take your ibuprofen, Tylenol, Motrin, whatever drug of choice you use, take it, because if you wait, you're going to, in the end, probably need a lot more drug to deal with that headache. Same principle with medications. Final slide. Do we need medication at all? Lisa Merrill, who I'm sure you all know, or at least know of, used to really be the nurse that was in charge of the methadone program in an opioid, and had a very big interest in opioids when she was over in Women's. She made a trip out to BC Women's Health Center and told them about our experience here with giving babies morphine. And they looked at her as if she was from another planet. and they said, what do you mean you're giving morphine to these babies? They said, we don't give any medications. And it's because it's a mother-baby unit. They admit all the babies and the moms who have opioids together, and they can stay as long as they want, lots of skin to skin, lots of breastfeeding, and they don't need to use the medication. So what does that tell me? That tells me that the non-pharmacologic methods are very, very powerful if you can do them. Our problem is being able to enact this, but I think this is the future. I think at some point you're going to find government will come around to realizing that we should do something like this. So that's that.
Mhm.
And that took us 12:45.
Yeah.
Not bad. 40 minutes. Okay.